It is a great pleasure to welcome you, our local faith leaders, community leaders, and all other concerned community members to this panel discussion on race and place amid COVID-19. This panel will allow us to discuss the increasing concern of how COVID-19 is impacting the African American communities in our region, how it impacts the way we work, the way we worship, the way we connect with each other, the way we navigate our neighborhoods, and the way we love on each other. As a people, we are rooted in resiliency. Our history is clear on that. However, there are many myths and misconceptions that are flooding our churches, they're flooding our communities and our neighborhoods. And we have the responsibilities as community leaders to set the record straight. It is my honor to introduce to you our distinguished panelists to do just that. First, we have Dr. William Cody, obstetrics and gynecology at Ascension, St. Vincent's. Dr. Timothy Gruber, president of Physician Alignment and Enterprise for Baptist Health. And Dr. Leon L. Haley Jr., Chief Executive Officer of UF Health Jacksonville, Dean of UF College of Medicine Jacksonville. Dr. Pauline Roll, Interim Health Officer and Medical Executive Director of the Department of Health, Duval. Dr. Floyd Willis, Assistant Professor of Family Medicine at Mayo Clinic, Jacksonville. To our audience, we need your support to help make this event a good experience for everyone. Please leave your video turned off. Your microphones will remain muted. However, we want to hear from you. So please type your questions into the chat area of your screen, and you will find your chat button at the bottom of your screen. If you have questions for our panelists as we move through this session, or if you have questions, technical questions for our team, please feel free to type those questions in the chat area. We will first hear from Dr. Timothy Gruber with Baptist Health, getting to the heart of the matter and the role of the Black church leader as influencers. Dr. Gruber.
Mortality and morbidity. Our national statistics confirm this, as well as our local stats. One notable example of this is what you see happened out in Louisiana, where African Americans represent about 32% of the population, but 70% of the COVID deaths. Now, if we look at our own stats here locally, not quite as bad, but just it's skewed just as much, I'd say. So the logical question would be, why is this the case? We all know that health disparities in the Black community is not a new phenomenon. One politician is quoted as saying that when America catches a cold, Black America catches pneumonia. That pretty much sums up the situation here. Chronic medical conditions such as hypertension, diabetes, asthma, obesity, combined with limited access to medical care and health services are really the primary drivers, but it doesn't stop here. We have what we've labeled the social determinants of healthcare, which are those social variables that can influence up to 80% of health outcomes. These include things such as access to healthy food, transportation, health insurance, education, your zip code, frankly, where you live is an important factor. So then there's this issue of institutionalization or imprisonment. No secret, Blacks are overrepresented in the prison system. And in that setting, there is a very low likelihood that social distancing is occurring. So for all these reasons, if you're African American and you're infected, you most likely will have a poor outcome. When the Safer at Home order went into effect, it did not apply to essential workers. And if you look in our hospitals, our local businesses, who's primarily responsible for environmental services, for food services, and in our city at large, you look at the grocery services, bus drivers, bus riders, delivery workers, you quickly see that there are disproportionately more African Americans classified as essential workers. And I will say that there is a huge difference between essential and indispensable, because you are essential does not mean that you are indispensable. In fact, these are typically hourly wage workers who are most susceptible to layoffs and reductions in pay. When we opened our citywide testing sites here in Jacksonville, they were all drive-through sites initially. So if your primary means of transportation is public transportation, you couldn't really take the bus to one of these sites. So of course now we have the walk-up sites, but these came much later. Then you have to consider that if you are an essential worker and rely on public transportation, there are fewer buses running. This presents a whole new set of challenges. So getting back to the virus itself, COVID-19 exhibits a very efficient transfer from human to human. Excuse me. I'm sorry, we're having a little technical difficulty. Great.
Okay.
So getting back to the virus itself, COVID-19 exhibits a very efficient transfer from human to human. It's probably one of the most easily transmitted and infectious viruses we've seen in many years, even more so than the measles. And most people, young people, really don't even know what the measles are. That's because the vaccine was so effective, but it was a very contagious disease, the measles was. So when you combine all of the factors that we've mentioned with the lower rate of testing among African Americans, and knowing that 50% of people with the virus have mild to no symptoms, but are effective carriers nonetheless, we have a perfect storm. The burning question is then, how are we as a spiritual community and a socially responsible society to respond? What's the responsibility of our neighborhood association and our PACs? Specifically, the church is one of the oldest and most respected of all institutions, especially in the Black community. We enjoy a position of great influence, and our parishioners and our communities, they look to us for leadership and direction, especially so in times of crisis. So along with this elevated position of respect comes a great deal of responsibility. There are 4 things that I'll mention now, and they are certainly not limited to the faith-based community, and it's not intended to be an exhaustive list. Number 1, the first thing we must do is pray. 2 Chronicles 7:14 says that if my people, which are called by my name, would humble themselves and pray and seek my face and turn from their wicked ways, then will I hear from heaven and will forgive their sin and heal their land. Number 2, we must educate our congregations and communities on the dangers of this disease, specifically how it is transmitted, so that we lower the risk of contracting it and spreading it to others. Now, others on the panel will give you more detail about that perspective, but we should identify as leaders sources of reliable information that we can use, and take that information and distribute it throughout our membership databases, and so that we become a more informed community. Number 3, we have to model and promote safe behaviors. This will certainly cause us to alter some of our standard practices. Our churches are typically well attended. That's a good thing. We like to shake hands, we hug, we kiss, we commune. However, I will say, until there's a vaccine, we should be following the guidance of the CDC and other credible health organizations. So when we're sharing those best practices with our congregations and communities, we will have credible information. Then lastly, we must continue to encourage and support the behavioral health needs of our congregations and our communities. Social isolation has unmasked a myriad of mental challenges, and I strongly suggest that we remain attuned to this and identify resources that are available for our congregations and our community. So the myth, African Americans can't get this. It's a hoax. White people are making it up. Now, it would have to be a really incredibly well orchestrated undercover operation that would require an enormous amount of collaboration, the likes of which we've never seen in our lifetimes. World leaders would have to conspire with scientists in almost 200 countries and would have to have medical professionals on 6 different continents agree to engage in this nefarious activity. The World Health Organization, the National Institutes of Health would also have to be participants, but more incredulous would be you'd have to have various news outlets agree to conceal the truth. Now, we've become such a polarized nation. There is no way that the Republicans would not rat out the Democrats and the Democrats would rat out the Republicans. Now, I can say personally that I've committed anywhere from 12 to 16 hours per day for the past 2 months, caring for these patients in one way or the other. That said, without any hesitation, I can unequivocally verify that COVID-19 is not a hoax. Thank you.
Thank you, Dr. Gruber. Now we'll hear from Dr. Leon Haley.
Good afternoon. Hopefully you can hear me well. As Ms. Sherman said, my name is Leon Haley. I have the honor and privilege of serving as the CEO of UF Health Jacksonville, as well as Dean of the College of Medicine. I'm an emergency physician by training and have done so for actually now 30 years, practicing in inner city Atlanta, Detroit, and now Jacksonville. So here's the myth. We should not take the test because they are giving the virus to African Americans with the swab. And so I will also, along with my friend Dr. Gruber, say that is a myth. It is false. In fact, it is the exact opposite. Taking the swab, taking the test is a wonderful opportunity for us to understand the extent of this disease. And obviously, it allows us the ability to try and trace the disease so that when we have a positive case, we have the opportunity to identify who that person may have had contact with and who they may have had in contact with so that we can mitigate the point of disease. But let's take a step back. As Dr. Gruber said, this is disproportionately affecting African Americans in our community. In the state of Georgia, 83% of the hospitalizations are in African Americans. In the city of Chicago, 70% of the deaths are in African Americans. In the city of Detroit, 40% of the deaths are in African Americans. These are statistics that we can no longer tolerate. It's unfortunate that it took a disease like this to identify and highlight the health and racial disparities that we have all known for many, many years. In the United States right now, there are over 1.2 million people that have contacted this virus. There are over 75,000 deaths, and that number continues to climb every day. Testing is important so we can continue to mitigate the disease. Patients generally fall into 2 categories, those that are asymptomatic and those that are symptomatic. The symptoms of the disease are actually relatively straightforward, but span a pretty big spectrum. And as we have seen, there are patients that can be completely asymptomatic. There are those with mild symptoms, and obviously there are those with major and severe symptoms. But typically we worry about cough, shortness of breath, difficulty breathing. There was a patient who recently described the feeling of an anvil sitting on their chest, or felt that they were swallowing water constantly. In addition to those, you should worry about fever, chills, shaking chills, significant muscle aches, if you've ever had the flu, that degree of pain, bad headaches, sore throat, and interesting enough, a sudden loss of taste or smell. Those are important things for you to watch out for. And certainly if you have all of those, we would ask that you would present yourself to a testing site or emergency department to make sure that we can adequately test you. But the bigger group that we worry about is the asymptomatic group. right? Those patients who actually have no symptoms, but may have disease and may be at risk for spreading that to an individual. As Dr. Gruber said, this is a highly infectious disease. Any one patient with COVID-19 can infect up to 3 people. That's much more significant than the flu, which is typically 1-to-1. But let me give you an example. In Seattle, Washington, which was one of the original hotspots of this disease, there were 76 patients that were tested in a skilled nursing home facility. 23 turned out to be COVID positive. Of those 23, 10 of those cases were symptomatic, but 13 of those cases were asymptomatic, and then they spread that to the other members of that community. So that screening that we worry about can, in fact, miss patients. Because of that, you've seen both the city of Jacksonville and across the state, and an increasing number, setting up testing sites so that we can begin to test people who are symptomatic and those who are asymptomatic. It started off at the Prime Osborne Center or TIA Bank, and then there are a number of places that have chosen to do testing. One of the things that we decided to do as UF Health Jacksonville, as the region's premier safety net, we decided we had to have the opportunity to take that testing back to the community directly, so that if patients were dependent upon cars, we would take that out of the equation. So in the neighborhoods that surrounded us, we started testing back in early April. This was with great support from the governor's office and the Department of Health and the University of Florida in Gainesville. And it allowed us to test both symptomatic and asymptomatic patients. In the process, the asymptomatic patients were actually asked to enroll in a research study so that we could figure out who they had in contact with and be able to trace the degree of asymptomatic spread in our community. Over 18 testing days at multiple sites in our region, we tested almost 1,700 different patients, if we include recently our opportunities to test in the homeless shelters. Interesting enough, there were 12 positives. So it's not a big number, but the point is we had the opportunity to be in the community to test in our patient population, which, as it turns out from a demographic standpoint, as you can imagine, was 90% African-American, 9% white, 1.4% other. But as Dr. Gruber said, part of the other challenge is this is a patient population that already has significant health disease. Right? Hypertension was number 1, diabetes number 2, seasonal allergies number 3, asthma number 4, COPD, congestive heart failure. So all of these make the patients at risk on a regular basis, right? So we performed our last community testing day today. We would encourage you to continue to use one of the available sites for that, because it's important for you to continue to be tested. We're working on a city group and a state group to test 5,000 people in the city of Jacksonville per day by early June. And the state is working on an initiative to get the 40 to 50,000 tests across the state of Florida per day. But for right now, the existing site that I would recommend is the Henry Brown Coker Park. It's part of the city of Jacksonville. It's available from 9 to 5 every day, obviously weather permitting. It's located at 1400 East 20th Street. In zip code 32206. The cost is free. It's open to everyone. It's 200, it has a capacity of 200 people per day, and people can walk up to the tents and be tested for screening. The results are available within 2 to 5 days, and there's a way for you to follow up in case you don't receive that. So I'll go back and say, we should not take the test because they are giving the virus to African Americans with the swab. That is unequivocally true. In fact, it's important to continue to be tested because when we look at our predictive analysis tools, we are doing a good job with distancing and the masks and all the procedures. And there is the chance that the virus does go down, doesn't go away over the course of the summer. But if we're not careful and we don't continue to test and trace, then the disease and the virus has the potential to come back up in the fall and in the spring. And then we have to do a second shutdown, which, as you know, has both a health and an economic impact. So I'm happy to stop there and look forward to the rest of the panel and the questions.
Thank you, Dr. Haley. Next, we'll hear from Dr. Floyd Willis on why has this virus hit the African American community so hard, and what should families do about it? Dr. Willis?
Good afternoon. You hear me now? I'm Dr. Floyd Willis. I'm a primary care physician at the Mayo Clinic here in Florida. I have been on staff here in the Department of Family Medicine for 27, almost 28 years. It's been my distinct honor and pleasure to practice here in town, and particularly to have so many community partners, particularly the churches, to work on various projects that we've had ongoing in the community. Many of those projects have focused on enriching research projects with underrepresented minorities. Very often, work goes on, not in the time of COVID, but work goes on, and we as African Americans find it difficult and sometimes personally challenging to extend ourselves to this kind of work. I bring that up because I want to take the opportunity to acknowledge something about this first particular question. The new coronavirus was deliberately created and released by a government agency or other group. So I would echo what Dr. Haley has said and what Dr. Gruber has said. It would be an enormously orchestrated event to really create this and release it on purpose. Nevertheless, I would be remiss if I did not acknowledge the history that Blacks have had with the United States healthcare system. It's important to understand that urban legends and proverbs such as this are rooted very often in very, very real experiences that people have had over generations. So we don't want to dismiss them too quickly. We want to understand the root of where they came from, acknowledge that root, and do the best we can to educate and re-educate that so far as we know, that is history and we are in a new day and such atrocities would not occur any longer. Now, having said that, to get to the point of was it deliberately created in a lab? Most likely not. All of the scientific data would suggest, and when I say scientific, looking at the genes and the actual makeup of this virus and then comparing it to the makeup of viruses that have been found over years in bats and other animals, the data would suggest that this was not created by man because there's so many similarities and transitions that make it evident that it came from animal to human. That's what most scientists would agree with right now. At the very same time, if you listen to the news tonight or if you heard it over the last few days, without a doubt, there are people suggesting that perhaps it was from some lab. And these suggestions are coming from the highest offices in the United States. So we're getting very, very mixed messages about it. I say all that to give you background, but say I don't know whether I'm comfortable truly answering that question because it's probably beyond the scope of this particular discussion. Probably is moot anyway, because if you think about it, this virus could actually have been captured from an animal, brought to a lab, and released, not created at all. But I, for the record, don't believe that happened. It would just take too much work and too much coordination. So the answer, I think, is I believe that truly is a myth. At this point, I do not believe this was released by an agency on purpose or a government on purpose. I'll shift to something different and say that with all that having been said, we have work to do now regardless of how the virus got here. Conspiracy theories all aside, we've got work to do with regard to why does it affect African Americans disproportionately. The Centers for Disease Control that would give three top reasons as to why it's affecting us disproportionately. Number one, underlying health concerns. So the disease burden that we already bear as African Americans, most importantly, diabetes, hypertension, heart disease. And I say underlying health concerns because it's not always just health diseases. Concerns might be less health insurance, lack of access to health care. But if we put all that in the big bucket, the underlying health concerns are, those kinds of things are stacked against us in the Black community. The second thing that the CDC says is living conditions. African Americans live disproportionately in more dense areas, more densely populated areas. We still have more households with multiple generations. And as my distinguished colleagues just talked about, if there's someone in the household that walks in with the disease and you're there with 2 or perhaps 3 other generations of your family, many of whom might be at increased risk, there's a higher likelihood of transmitting it. So number 1, underlying health conditions. Number 2, the living conditions. And third on their list is work conditions. People of color, African Americans, and people of Hispanic descent, Latinos, work disproportionately in service jobs. We're out and about more, exposed more. And in addition to that particular work circumstance, the work condition of having less paid sick time, and again, we just mentioned less insurance coverage. You add those 3 things together with a list of several other things, it reflects back upon what I think Dr. Gruber said early on. And it's an old urban proverb, you know, when America gets a cold, Black America may get pneumonia. These are, we lump into social determinants of health. A lot of it could be improved and resolved if the things that impact us socially could be rectified and the playing field could be leveled. So that's at a very, very high level why these things I think disproportionately affect African Americans. And I'll move quickly to the next myth.
Thank you.
You don't need to isolate from relatives. Well, we just talked about the top 3 reasons why we're disproportionately affected. One of the things that we can do about that uneven playing field, is know the guidelines and follow the guidelines and understand that if we have exposure to the disease or we have the disease, if we expose ourselves to our relatives, they may very well contract the disease. That is a myth that you don't need to isolate yourself. Yes, you do need to isolate yourself from your relatives if you have the disease or you have been exposed to the disease. Very important to know the symptoms, which Dr. Haley just talked about, to have a resource, a trusted resource that you can go to decide whether or not your symptoms merit a call to your personal physician or your local health department. Follow those guidelines, and if it calls for you to isolate yourself from not only your relatives to protect them, but sometimes, and this is exceedingly difficult, but sometimes to protect your community, one has to isolate themselves for 14 days. And that can be very, very difficult under many circumstances. So I'll stop there. And I think later in the discussion, we may talk a bit about some of the specific disease processes and why they might predispose us and others to COVID and the illness of COVID-19. Thank you.
Thank you, Dr. Willis. Now we'll hear from Dr. Pauline Roll on how do we protect ourselves from COVID-19. Dr. Roll, will you unmute yourself and turn on your camera? Dr. Roll? Dr. Roll, you are unmuted, but we can't hear your sound. So we're going to work on that, and we're going to move on to Dr. Cody. So we'll have Dr. William Cody.
I am here. Good evening, everyone. I'm Dr. William Cody. I'm an OB/GYN physician, and I have practiced here at St. Vincent's Ascension Healthcare System for the last 28 years. Prior to that, I spent 13 years in the United States Navy. The question that I had been asked to address at the topic is, what can we possibly expect in the future? When I take a look at the number of individuals listening to this broadcast this afternoon, I think that we are making an impact in trying to get the message out to our community, especially to the Latino, the Black community, other minorities who perhaps don't have access to the technology. I appreciate the collaboration that we've seen from the healthcare systems in our city. And Dr. Haley and I were just presenting information the other night to individuals, and one of the comments was having access to testing centers here in the city. Dr. Willis and I also belong to the same organization, and trying to get the word out to the community to take this virus very seriously. The format for this discussion in terms of myths, I think that in the future we have to continue to attack the belief that there's not scientific evidence behind how serious this virus is. Flattening the curve, the kinds of things that we have to do. Wearing masks, washing our hands, social distancing. All of these things we have to carry into the future and to teach our families how to appreciate this. Just here in Jacksonville with relaxing and looking at the community beginning to go back to the beach, we have to question if our society is really taking what we're saying here seriously. The myth about the virus starting in a lab and being sent around to the world to infect people, I think that we've done a reasonable job of trying to dispel that. The zoology, transmitting the virus from an animal to an intermediate host into humans, and the way we transmit it to each other, and understanding how to protect ourselves and communicate with our healthcare system. Nobody cares about our community, the myth that I was asked to address. I think the mere fact that we have this format tonight, trying to educate our community, trying to educate our families and our friends to protect ourselves from the virus. Just even in my own practice now, when an obstetrical patient comes in, the patient's asked to have a mask on. We're not allowing any family members to come in with the patient. When patients are coming to labor and delivery at St. Vincent's Medical Center, we have to identify an individual that's going to be with the patient, and that person will stay with them for the duration of the labor process. So a lot of things are changing in the future in terms of what we as a society and what we as a culture have become accustomed to. And I think if we continue to share information with each other and talk about the ways to help get the information out to the public, to encourage patients to do the testing, that will have a positive impact, and hopefully this will carry into the future with us. Lynn?
Thank you, Dr. Cody. We'll check to see if Dr. Roll is able to speak with us. And she's still having some technical difficulties with her sound, so we will move forward to some of the questions that we have. I want to remind the audience that you have an opportunity to ask questions of our panelists by typing them in to the chat space. And in just a little bit, my colleague Anne-Marie Knight will be collecting those questions and posing them to the panel. But I'd like to propose a question or pose a question to a few questions that we already have from the audience. And this question is to Dr. Haley. Dr. Haley, what factors should be considered before a person comes to the emergency room for non-COVID-19 emergencies?
That's a great question. And one of the things we've tried to emphasize all along, but certainly recently, is we don't want anybody to stay home if they believe they're having a medical emergency. So if you're having chest pain, shortness of breath, you think you're having a stroke, we absolutely still would like people to come to the emergency department and still use it appropriately. Well, one, some of those symptoms could be COVID, right? There is some literature that comes out of Italy where 30% of the patients who presented with stroke were actually COVID positive. There is some literature around cardiac disease. There's definitely literature around sinus disease. So we're asking people that the emergency departments are still open, they're still available. In fact, most of the emergency departments across the country, and ours included, the volumes have gone down. So there is an opportunity to be seen. We are testing people when they are symptomatic and appropriate or meet one of the criteria. I know somebody asked a question about sort of testing everybody, and one of the rate limiting steps across the entire city, state is actually the number of tests. So for the moment, we are screening people based upon some of their signs and symptoms to make sure they're fitting some of the CDC guidelines. But we also don't want people to not come to the emergency department and get ill. Some of the other literature from New York and Chicago, when you look at sort of people who are sick and not coming in, that number is high, and it's actually showing up in some of the death rates. So the emergency departments are open. People have the appropriate PPE. They have the appropriate testing if necessary. So we would like to encourage people that if you believe you're having a problem, please come and see us.
Thank you, Dr. Haley, for that information. I have a question too for Dr. Willis. Dr. Willis, if an African American has hypertension or diabetes that is well controlled by medication and they contract COVID-19, are they still considered at high risk or at a higher risk than someone without these diagnoses?
That is a two-part question, probably a two-part answer. I will give what I think might be the most prevalent situation that people would be in. The long and short of it is the way that that diabetes makes people who have who get infections are more susceptible. The way that that works is the diabetes over a period of time damages the way the immune system works. And the way that it does that is simply the blood sugars being too high over a prolonged period of time. And I was in conversation with one of my colleagues about this in recent weeks. And even when the blood sugars are well controlled based on what your own physicians, and actually what I tell my patients, if your A1C is 7, below 7, by national standards, that's considered pretty good control. However, it's not perfect. And if those blood sugars are up, it's doing little teeny bits of damage to your immune system. So you would be at increased risk for complications from any infection. Now, the second part of that is if you're that fortunate diabetic who's taking their pills every day, taking their insulin every day, and their blood sugars really are great, and your A1C is less than 5.7, it's really, really good, and you have not had a period in your life of 5 or 10 years when it wasn't well controlled. It's always been really, really good. The literature would suggest that you may not be at any greater risk of these complications from infections as someone who does not have it. But it is it's an honor and a privilege to work with folks who are able to keep that A1C down that low. That's a lot of work. It's exactly what we should aspire for. But that's the way I think I would suggest people look at that particular aspect of infection with diabetes. Are you perfectly controlled or not? If you're not perfectly controlled, be very careful. Don't expose yourself if you don't need to. If you think you're having symptoms, get access, talk to your healthcare provider, because you are most likely at increased risk.
Thank you, Dr. Willis. Don't forget, audience, to put in your questions in our chat section. You can see the instructions on your screen. If you're looking at it, just click on the button that says chat and just type away. Type whatever question you'd like to ask us. That might be one of the panelists, or it might be a technical issue.
Lynn?
Yes, Dr. Roll, are you ready?
Can you now hear me?
I can
Yes,
hear you.
I'm sorry. Things work perfectly in a run-through, but not always so well in live.
Yes, that's okay. Technology is incredible. So, ladies and gentlemen, let's hear from Dr. Roll. And Dr. Roll is going to speak to us about how do we protect ourselves.
Good afternoon. As said, I'm Dr. Pauline Roll. I'm the Interim Health Officer and the Medical Director for the Florida Department of Health in Duval County. It's my pleasure to be a part of this panel. I hope you all are getting something out of this. This is indeed a great opportunity. So please ask your questions tonight. We don't want anyone to go away without their questions answered or feeling like they didn't get what they came for. So the myth is wearing a cloth face covering or mask will protect me if I'm around anyone who has COVID-19. Well, the face mask is only part of the story. And so while certainly wearing a face covering is helpful, it's first of all important to wear it properly. So if you look at these pictures, the first picture demonstrates someone who is indeed wearing it properly. However, the pictures on the bottom, that is not the way to wear it. So look, I see a lot of people in public with it below their nose, which is demonstrated in picture one. That's not doing anybody any good. The other is face mask completely off. And then when you put your face mask on, you need to make sure that you don't continue to tug at it because that loosens it up and that also potentially exposes you to germs. And so it's important when you put your face mask on to make sure it fits properly so that you don't have to continue to maneuver it. And of course, the fourth picture again shows someone with the face mask completely off, and the last picture is just totally off. And so if you're going to wear a face mask, it's important to wear it properly, make sure it fits snugly. And you, if you have the one with the ear loops, make sure it's completely behind your ears. If it ties, make sure you tie it at the base of the neck and at the top of your head so as to ensure that you have the appropriate facial covering. The other part of this, again, the face covering by itself is only part of the picture. As it's been emphasized already, social distancing is so important. Staying at least 6 feet away from the nearest person, and oftentimes, again, when we're in public, folks don't necessarily respect that, and so we need to make the adjustments to ensure we keep ourselves safe. So if you looked at this picture, it shows you the power of social distancing. So you have one person who does not wear a face mask, does not social distance, does not use proper hygiene. They could potentially infect 2.5 people within 5 days, and then those 2.5 people can infect another 406 people in 30 days. So say we decrease the exposure by 50% by wearing a face mask or social distancing, then you may only infect 1.25 people in 5 days, and that person will only infect maybe 15 people in the next 30 days. If we combine social distancing, good hygiene, facial coverings, and things of that nature, you lessen the number of people that you infect. And so it is important to ensure that we do all of these things to protect ourselves. The next thing I want to talk about is hand hygiene. And so we know about hand hygiene. We wash our hands. We wash our hands before we eat. We wash our hands when we leave the restroom. We wash our hands. But we must teach our children the proper way to wash their hands as well, and encourage others around us to do the same. And so good hand washing is so important. And ideally, you should wash your hands for a total of 20 seconds. Now, if you count that out, that is a really long time. And I can tell you most people probably don't do that. But you want to make sure you wet your hands with water, apply a healthy amount of soap, rub your hands together. And this pictograph shows you specifically how you should rub your hands together, including your palms, The backs of your hands, you need to make sure you get those really good. Your fingers, really, being detailed is important. Making sure you wash your hands properly is important to get all of the germs off. There's also a hand sanitizer that you can use, but of course, hand sanitizer should be used in those instances where you don't have access to soap and water. Soap and water is always best, and it could be warm water or cold water. There is not a preference, but water and soap nonetheless are very important. And then you want to make sure after you've done all that washing and you've rubbed your hands properly, you want to make sure you dry them properly. And use the paper towel to turn off the faucet, and even to open the door as you're leaving a public restroom is always a good idea. So now your hands are clean. And so it's important to make sure you use hand hygiene every time, consistently. And again, teach your children, because I've seen children often, they'll do the palms of their hands, but they don't necessarily always get the backs of their hands. And as a pediatrician, I'm always watching the little kids to see how they handle situations. And so it's important as adults, we also teach our children to do the right thing with hand washing. And so again, cover your cough, social distancing, wearing a face mask, hand washing, all very important. I'd like to share some statistics with you regarding the total number of cases here in Duval right now. Right now we have 1,083 cases and 28 deaths. And approximately 34% of those are Black and 41% are white. And so certainly we have a good number of that shows that Black folk do get it. Yes, indeed, for those who thought that was not the case. I do want to mention that the Florida Department of Health in Duval is willing to come out and do testing in the home for those who are disabled and homebound. If you do not have the ability to get to one of the testing sites and you are disabled and homebound, please give us a call. Our number is 904-253-1850. Again, 904-253-1850. We are here to help, and thank you again for having me tonight.
Thank you very much, Dr. Roll. That's great information. And we have had one question to come in for you, Dr. Gruber. I'd like to ask you this question from our audience. What should we do when a person who is a confirmed COVID-19 case has been in the church or in the community facility, regardless of the community transmission rates? What should we do? How should we handle that?
Well, I'd say the first thing I would do is contact the Department of Health. They can give you some specific directions about how we trace individuals. If the person has tested positive and you've been exposed to someone that's tested positive, you should certainly go get testing for yourself. But in these large settings where it's kind of difficult to know who you were exposed to, it does become problematic. And then it gets back to the first part of our discussion, how critical it is for us in the church environment and other large gatherings to social distance. And it will fundamentally change how we've operated in the past, but it is so critical for us if we're going to mitigate the spread of the disease.
Thank you very much. Thank you very much. Now we have questions that are just pouring in for this panel, and my colleague, Anne-Marie Knight, is going to facilitate those questions. Anne-Marie?
Hi, good afternoon. Can you hear me okay?
Yes.
All right, as Lynn said, if you look through the chat, there's a plethora of questions, and realizing that we have a little bit, maybe 8 minutes, we're going to pick a select handful, but we assure you we are going to consolidate the list and reply to these questions, and you'll have that information. So the first was from James Wiggins, and Dr. Willis, this question will be for you. How can we determine when the time is right to reopen our churches?
How can we determine when the time is right to reopen the church?
Yes, sir.
That is a difficult question. That is reaching often beyond the science and into the politics, being quite frankly with you. there are ongoing discussions between church leaders and the mayor's office as we speak. And the discussions are to come to some consensus about when it would be very, very safe to reopen the church, understanding that opening the church is going to automatically increase the exposure, and if there is not proper social distancing, it could be catastrophic. So what I have suggested to our pastoral leaders who have been in consultation with us is to follow this along for now, to be certain to look at the Centers for Disease Control guidelines for pastoral leaders. There's an entire section that describes what needs to be done, including a catastrophe leadership team and a task force for pandemics to begin to carefully plan when this should occur. My opinion is that when there is significantly more testing, massive testing, and when people know who does and does not have the disease, and when they can better understand who is and is not walking around asymptomatically, then we'll have a better idea of when it's time to physically open the churches. Right now, if I were counseling my own personal patients, many of whom who are elderly, many of whom are at increased risk for COVID-19 complications, I have not suggested that they return to those kinds of group settings at this point. The best answer I have, and it seems as though these guidelines change every 72 hours or so, so we promised them on a phone call today that within a week we would have the best update we can on what's being said about reopening churches.
Thank you, Dr. Willis. Bear with me 1 second. My screen kind of scrolled down, so I apologize. All right, the next question is going to go to Dr. Gruber. It's from Joni Portier. Apologize. She says, great discussions. Is antibody testing recommended? Is it available yet in the Jacksonville community?
Great question. Yes, antibody testing is available in our community. There are a couple of labs that are doing it. Of course, LabCorp and Quest, and even some of our in-house labs are testing for antibodies. But I will say it's very controversial of what the results mean, and others on the panel will probably agree with me. This first, the concern is if your test comes back and it does have the antibodies and the test, does that confer immunity? And secondly, how long does that immunity last? If you get a positive test, it would, and you have not actively had disease that you're aware of, it could certainly bring about some level of confusion. So I do think there's a lot of promise, a lot of hope here, but there are a lot of questions as it relates to the value of the antibody test.
Thank you. The next question is for Dr. Cody. It's from Tiffany Clark. Ms. Clark asks, will it become difficult to adhere to the social distancing guidelines as more restaurants, retail stores, and other businesses open in our community? Dr. Cody?
I think there's going to be a real challenge for the entrepreneurs because people are desperate to get their businesses back afloat. And we've all seen the economic impact on this. And social distancing is going to limit the number of individuals that can come into the restaurants and other public places. Social distancing is going to be a major part of trying to flatten the curve. So the answer to your question is yes, this is going to be a challenging task that we'll have to address.
Thank you. Dr. Haley, the next question is for you. It's from Mia Jones. Do you have a concern with the self-testing that is starting to be talked about?
Yes. That's all you get. No, I mean, I think right now, and this piggybacks actually on Dr. Grover's point around serologic testing. So right now the market is being flooded with tests, at-home tests, serology testing, and they have not been validated by the FDA. They haven't been proven to be valid. There's already a 30% false positive rate on the existing tests that have been approved. So I would have serious concerns at this point on the at-home tests. I think we need to, I think there is promise with it later on, kind of what Tim just said, but it's too early in the equation to rely on them.
Right. Thank you. I know we're almost at the top of the hour. I'm just going to squeeze in one last question for Dr. Roll. And Dr. Roll, this question is from Jay Sapora. The state demographic health data appears to indicate that the ethnicity and race of about 15% of the patients are unknown/no data. So how can the basic demographic reporting be improved to get more accurate data to assess the challenges?
We recognize that a large proportion of those are unknown, so we are working to clean that data up. We have various data sets that we can use to match the data, as well as following up on the cases allows us the opportunity to delineate what race and ethnicity the positive cases are. And so that data should start to look better in the next few weeks. But we did recognize that that was an issue because when folks got tested, they did not indicate their race or ethnicity. And so we are in the process of following up with cases in the community to ensure that information is properly captured.
Thank you. And with that, despite the fact that we have numerous other great questions, I'll turn it back over to you, Lynn.
Thank you, Anne-Marie. I want to reassure our audience that you will get your questions answered. We will contact you with a response to your question from the panelists, or if there's any technical questions that you might have. But on behalf of the Jacksonville Nonprofit Hospital Partnership, I want to thank our panelists for sharing this critical information with us tonight. And I want to thank our audience for the passion and concern you have about keeping our African American community safe and healthy. All of our registered audience members will receive in your email a link to a recording of this session for you to share with others in your family, in your church, and in the community in which you live. You will also receive a list of some of the frequently asked questions with an answer to them, and a copy of the hand washing and the proper way to wear your mask handout. You'll also receive a link to a very, very important survey that we would like for you to complete about this program. This will help us, help you, and the rest of the community. So thank you again, everyone, for your time, and good night.
Thank you.